Hi, everyone. Thank you for joining Dr. Jeffrey Carey's webinar tonight on regaining bladder and bowel control. This evening, we are going to hear from Dr. Carey about bladder and bowel dysfunction and treatment options available to help you regain control. My name is Shannon Stemke, and I'm a field marketing specialist with Axonics Therapy, and I will be moderating this webinar. Without further ado, I'm very excited to introduce you to Dr. Jeffrey Carey.
Hello, everybody. Thanks for coming out and taking some time to learn and listen about things we can do to help. So we're going to talk about bowel and bladder control this evening and go through that with you. I am a urologist by training, and then I additionally did a urogynecology fellowship. So I focus on female pelvic medicine as well as voiding dysfunction and incontinence in both men and women, given my urology background and then the subsequent subspecialty training in urogynecology. I bounced around a little bit. I'm originally from Ohio, went to Miami of Ohio for undergrad, and then spent some time in Toledo as well as in Detroit, and then out to California for fellowship, and then home to here. So we've got offices all over the city, so we try not to make you drive too far if we can avoid it. So the things we're going to talk about are bladder and bowel symptoms. These can be miserable problems that can affect all phases of your life and impact the quality of your life. And the key messages for all of these things are that this is just not simply part of getting older. You oftentimes will have people try to tell you that, I'm getting older, so I'm supposed to leak, and you'll have the pad companies tell you that, I'm supposed to leak, so I should buy your pads. And, it has nothing to do with what you did. It's just things that happen to strike people the more years they march through. And these problems can strike people in their 20s and 30s and then throughout the rest of their life. And they're never considered normal. Even in our 90s, although it's more common, we shouldn't be leaking urine or stool. And we're going to talk about all those fun things tonight. They can impact all phases of your life. They're socially isolating, make you want to avoid leaving your home, spend a ton of money on pads. They can affect your ability to work. Obviously, can be pretty depressing and disruptive. We're going to dig into, what are the different things that the different types of accidents that we're going to be dealing with. And we're going to start with a condition known as stress urinary incontinence. This is a very common condition that happens in both men and women. These next slides are going to focus more on female side of things, but this also does occur in male patients after prostate cancer or other prostate procedures. So on the female side, this is mostly due to vaginal deliveries and the trauma associated with vaginal deliveries, and it results in problems of a weak seal at the exit of the bladder. Common condition, like I mentioned, 1 in 3 women at some point in their lives will deal with stress incontinence. Usually the initial damage occurs at the time of vaginal delivery, and then the subsequent stress incontinence develops in the decades that follow. There's numerous treatment options for stress incontinence. This just mentions the primary options of pelvic muscle exercises, either that you do on your own, known as Kegel exercises, or you can also do them with a women's health physical therapist or physical therapist for men as well that treat stress incontinence following prostate procedures. There are options for sling procedures as well as urethral bulking. We're going to dig into some of those options in the following slides. Stuff you can do to help. We mentioned the pelvic floor exercises. People don't think about their pelvic floor, but it's the place where all these things live, your bowel, your bladder, and strengthening those muscles can be helpful to alleviate those conditions. Sling surgery is one of the surgical options. Sling surgery is considered the gold standard treatment for stress incontinence. These procedures have been around for numerous decades. Lengthy clinical trials show them to be one of the best, long-term answers. They do have some limitations where you may not want to undergo these types of procedures until you've completed your family planning. Urethral bulking has a renewed role in what we do for stress incontinence. We're going to talk about the bulking agent in a minute as far as the specifics, but urethral bulking is essentially a way to, I always talk about the urinary sphincter as the washer on your faucet. So if the washer on your faucet has gone bad, then no matter what the support of that area looks like, there won't be a good seal there and the faucet will leak. So urethral bulking works to sort of replace that washer on the faucet to help recreate that seal that's been lost. And this is a minimally invasive procedure done with a lighted telescope where we inject a material around the urethra. And bulking has been done through the ages with many different types of materials, everything from autologous fatty tissue to calcium beads to carbon beads and all kinds of other things. But the most modern version of bulking is the bulking agent Bulkamid, and we're going to focus a little bit more on that this evening. Bulkamid is a water-based gel that's injected through that lighted telescope to help improve the seal of that weak washer on the faucet.
Bulkamid can help provide the relief you've been longing for. The short, incision-free procedure typically takes less than 10 minutes. Involves 3 to 4 small injections of soft, water-based gel into the wall of the urethra to help prevent urine from leaking out of the bladder during day-to-day activities. It's safe, quick, and most patients can get back to your normal activities almost immediately.
So they just kind of touched on, the quickness of this procedure. It is the positives of bulking, compared to, say, for instance, sling surgery, are that the procedure is done in essentially about a 10-minute procedure. It can be done in a local anesthesia setting, but most of the time I feel that it works best for everyone involved if it's done under some sedation, so you're just more comfortable for it. But it does take about 10 minutes to accomplish. And the success rate of this modern bulking agent has eclipsed the success rate of our previous options that we had through the years. So in clinical trial, this was at a 1-year point in the clinical trial, 92% of patients reported success with this type of therapy. The drawbacks with bulking procedures are that, they may, fade a little bit faster than sling surgery. So, but given the fact that this is a procedure that you can do and then takes 10 minutes to do, and you can return immediately to your everyday life, including exercise the next day, that's the positive. So you can complete this procedure and return to running or jogging or whatever physical activity you want to do the next day, whereas sling surgery takes some healing time to be effective. So you have to restrict your physical activities for approximately 6 weeks to allow sling surgery to be healed and provide that long-term effective cure. With this, it's effective immediately and has good data compared to previous bulking agents. And so given that it is a 10-minute procedure with immediate return to physical activity, that's sort of the plus side of bulking. This is the part where we have to talk about all of the potential negative sides that can happen. This is that part in the commercial where we talk really fast about the stuff at the bottom that it might happen. So basically, when you look at bulking, the big thing is that we typically see is that on the day of the procedure, because we're working in the tube that you urinate through, you might have difficulty emptying your bladder. And that's typically a very short-term issue. Happens in my clinical experience about 5 to 10% of the time. You might have to have an overnight catheter to let your bladder get back to emptying. I've never seen, in all of 20 years of experience, have not ever had a patient with any type of bulking therapy have long-term difficulties emptying their bladder. But that's theoretically possible, but extremely low on the percentage chance. There's areas where we shouldn't be doing bulking. We don't do bulking in Bulkamid in patients that are male patients. This is not indicated for their condition. It's an entirely separate problem on the male side. So now we've kind of sort of walked our way through stress incontinence. We're going to jump to the other side of leakage. So the two types of leakage are the coughing, sneezing, exercise-induced leakage of stress incontinence. Now we're going to focus on what happens when you go too often and you can't make the bathroom fast enough. And that's what happens when you've got a bladder that doesn't store urine well. So essentially your kidneys are the factories of urine, your bladder's the warehouse. And when the warehouse doesn't store the urine very well, it becomes smaller in capacity. and that causes you to go more often. And that same warehouse those bladder muscles and nerves can begin to fire inappropriately, causing spasms that result in accidents associated with urgency. So this is I got to go and just can't make it fast enough. I got to run over people to get to the bathroom when I get the urge to go. Problems with emptying of the urine we'll also touch on as well as we move through the next treatment options. So what is overactive bladder? Essentially, the hallmark symptom of overactive bladder is urgency. So we all know that, if you've got to go to the bathroom, you're going to feel the urge to go. But urgency is beyond just feeling the urge to go. It's the overwhelming, compelling urge to go that if you don't get there, there's going to be an accident. And that's when it crosses over into something more pathologic. We think about 8 times a day is a typical, number of trips to the bathroom, and waking up twice per night is typical. When you start breaking those barriers, then you're moving more into what we consider an overactive bladder. Super common condition, 50 million people in the United States alone. And that's a lot of people. We're going to touch in a minute about loss of control of stool, and that's another large chunk of 19 million people with those types of problems. And the big thing about this is a lot of these patients don't even seek treatment, and they do that for many reasons. From they think it's not going to help, or they're embarrassed to ask, or just a number of different reasons why they don't reach out. Maybe they talked to a friend, they did something that didn't work, so they call that kind of sort of hairdresser or barber medicine, when you talk to your buddies and your friends, and they tell you they did something that didn't work, so you think it's not going to work for you. And these treatments are all very tailored to the individual. So we have lots of hope for making these things better. Fecal incontinence, we mentioned, happens in different ways, and it's also related to overfiring of those nerves in the pelvis, and it results in the same types of problems. Fecal urgency, where you feel the strong urge to go and you can't get there fast enough, or the complete loss of stool, or even the passive loss of stool, where you don't notice that it's happening and you're just getting some soiling or staining. The bowel functions in a similar way. It also requires nerve signaling, and it's these areas that are affected in bowel function loss. And the ones that we're going to focus on are these problems and conditions related to overfiring of those nerves to the bowel. The good news is that there's lots of treatment to help these problems. I never, when I was growing up, thought that I would be taking care of these issues. Nobody grows up thinking they're going to take care of incontinence problems. But the thing about this whole field that drew me to it is the fact that we really can change people's lives in a positive way. And so that's pretty rewarding stuff from our end. And although the problems are embarrassing and difficult to talk about, we oftentimes can get to a place where we really can make a difference. And so that's the good news. There's lots of treatment for these things. And like I mentioned, it's very tailored to the individual. And we start with conservative things, from behavioral changes to eliminating caffeine, to moderating your fluids, to going to the bathroom by the clock. And then we progress to treatment beyond that with medications. And then beyond those things, there are advanced therapies. So it begins with behavioral therapy, and then medical therapy with medications, and then we move on to advanced therapies. This slide talks about posterior tibial nerve stimulation. So PTNS for short. Believe it or not, the nerve that runs out of your foot and up into your pelvis, called the posterior tibial nerve, impacts the nerves to your bladder and pelvic floor. So in some very well-designed clinical trials of stimulating that nerve, they have shown that patients will respond to that therapy. And they did sham trials where they just made patients think they were getting stimulated, and that really didn't do anything. And then they compared actual stimulation to medications and showed that it can be as effective as medications. So the drawbacks of PTNS, is the difficult part of people adopting, is that you have to come to the office and hang out with us too much. And nobody likes to hang out in doctor's offices, not even me. So, it takes some time. So you got to come in once a week for a 20 to 30 minute session where we stimulate the nerve, where you can hang out and read a book. But you've got to do that weekly for the initial 6 weeks. Then we kind of assess how you're doing. If you think you're making progress, we do another 6 weeks. And then if you get through that 12 weeks, then it's once a month, essentially for the rest of your life. If you stop doing treatment, anything for overactive bladder, then as soon as you stop doing it, it goes back to its baseline bad behavior. So that's sort of the drawbacks of PTNS. There's some stuff on the horizon about potentially, implantable things you can do at home, but not quite prime time yet. But there's stuff out there. There's bladder Botox. So everybody's heard of Botox, cosmetic Botox, stopping the wrinkles in your face. This is a Botox for your bladder. It causes and impacts the spasms of the bladder to minimize those spasms. And Botox is done as an office procedure with installation of the bladder with a local anesthetic. And then we look inside with a lighted telescope and we inject the Botox material into the bladder muscle. So the Botox, positives are that it can be effective. The drawbacks of Botox are that it is never forever. So you've got to keep doing Botox. Botox, the longest duration of effect I've seen is about a year. So if somebody gets a year out of Botox, then that's pretty amazing. And so that's not too bad. They come in once a year, they do Botox injections. But the average is somewhere in the middle of that. So most people, the vast majority of people, it's going to be at least twice per year, sometimes even more than that. So the fact that you have to come and do a procedure at least twice per year, or maybe even 3 times a year for the rest of your life can be a little bit, daunting for some people. The other potential drawback of Botox is that it can result in incomplete bladder emptying, needing catheterization. Not super common, about 5% chance, and it doesn't last forever. Like everything with Botox, it never lasts forever. But if it's you and you're the 5% person who can't empty their bladder, and you don't like the idea of having a catheter or catheterizing yourself, then it may not be something that you want to consider. So the last category of things that we're going to talk about for overactive bladder and for the overactive bowel and fecal incontinence is sacral nerve stimulation. So the sacral nerves are the nerves that supply the pelvic floor, and they supply both the bowel and the bladder. And these procedures have been around for over 25 years. And we've been doing these procedures to help patients with bowel and bladder incontinence, as well as difficulty emptying their bladder. And the most modern version of that is Axonics Therapy, which we're going to focus on this evening. This is Jill and Melissa. I don't know them, but they look like happy people. So Axonics Therapy is sacral nerve stimulation performed for these 3 categories that you see in front of you. So those bladders that go too often, that result in urge accidents or too frequent trips to the bathroom, to what we call non-obstructive retention, where the bladder isn't emptying, but there's no blockage, and then loss of control of stool, fecal incontinence. So how does this work? It's a little bit of a mystery as far as exactly what's happening, but basically what's happening in the way I kind of describe it is that it's sort of acting like an electrical filter, a system to help to moderate or to dampen those overactive nerve firings that are generating the dysfunction of your bladder or bowel. And it sort of restores that normal communication by dampening some of those overactive and inappropriate signaling that's resulting in your bad symptoms. This is the 2 versions of Axonics and shows you on the R20 side, this is the rechargeable version. This is a device that lasts for over 20 years. We only wish we could get our cell phones to do that, but it allows you to go up to 6 to 10 months between recharging intervals. The actual size of the device is pretty much what you see on your screen, but I do have one here. I don't know if you can see that, but this is the, yes, you can. Okay, good. So the size of the device, pretty tiny. And so that is a very reasonable option for people that are looking for something with an incredibly long lasting battery life and a very small footprint. The other version of the battery is the non-rechargeable version, which is this. So this is the F15. But basically, this is approximately 10 to 20 year battery life, which has absolutely no recharging. Recharging, although we'd like to say it's perfectly simple and always perfect, there are some nuances to that, and you have to kind of work yourself into understanding exactly how that works. So, in my practice, if somebody isn't really focused on wanting that super small footprint, we usually sort of recommend the non-rechargeable version. But if someone wants that super small footprint, they're concerned about that, and they're into recharging things and learning how to do that, then we will go with the rechargeable version. This is the remote control, tiny little thing that fits on your keychain, allows you to turn your therapy up and down. And you're asking, what does that feel like? Why would I want to turn it up or down? Basically, with these devices in place, you feel sort of a gentle tapping or buzzing sensation down where you'd sit on a bicycle seat, in that area in general. And you have the ability to, increase the amplitude of that sensation if you're trying to adjust your therapy. And so this little handheld control allows you to do that. One of the things about this type of therapy in the past 25 years were problems with MRI access. So these devices in their initial phases, were not compatible with MRI imaging. And so MRI imaging isn't really needed all that often. We usually use CAT scans and other types of imaging, but for those cases where you do need it for neurologic issues, for soft tissue imaging, for bone and joint issues, then the ability to perform an MRI is a pretty nice thing to be able to do. And with Axonics Therapy, you can perform an MRI in both 1.5 or 3 Tesla full body scans without any issues there. Does it work? I always tell patients that sacral nerve stimulation is one of the most exciting things that we can offer patients as far as the impact to their quality of life. You go through a test trial process with sacral nerve stimulation. It's what I call a try it before you buy it technology. So how that works is you place little test leads through a needle stick, and then you have an external stimulation device which provides that stimulation during a test trial. Usually that test trial lasts about 5 to 7 days, where we monitor your symptoms, and then you as the patient are judge and jury about whether you think this has been an exciting thing. And the chance of successful test trial is pretty high. I tell patients about a 7 or 8 out of 10 chance that they're going to have a positive test and want to move on to the full implantation. And in those patients that adopt the therapy, who go through a successful test and have the device placed, they have good long-term data, as you can see in this 2-year data of 93% of patients still reporting clinically significant improvement. And this is patient self-reported data. So again, satisfaction is always important. I mean, one of the key things that we look at in successful therapy for patients is, what do the patients think? I mean, how do they feel satisfied with their therapy, and would they, tell someone else to adopt this type of therapy? And the numbers are pretty exciting for how Axonics Therapy and sacral nerve stimulation, those patients are still doing well and able to maintain that therapy over time. So as far as the talk really fast about things that it can do, part of things, we want to share the potential negatives. The good news about this type of therapy is that it's been around for 25 years and over, I believe, 400,000 these types of therapies across the globe during that time frame. So there's a lot of experience, and so the safety is legendary. There are potential things you shouldn't do, and this kind of goes through some of that, this slide. You don't want to be heating over it. You don't want to performing radiation therapy over it. You don't want to be doing other things like that. It talks about these are batteries, and you shouldn't try to rupture them or pierce them, which is pretty common sense. I've had a patient who got kicked by a horse once that made one of these devices not work, but in all of my 20 years of experience, I've never seen a battery, open up in some way. So they are incredibly sealed, so that just doesn't happen. But this is talking about, they have to cover everything with the FDA, and you wouldn't want to, of course, puncture the device, which makes sense. Some of the other adverse events, these devices are placed under the skin. You could potentially, develop discomfort at the site. There's the possibility of people describing, uncomfortable stimulation. In general, the stimulation is a very background, unnoticeable, buzzing or tapping sensation. But some patients may report increases in those stimulation they find uncomfortable. Usually that's simply, adjusted by decreasing your stimulation with your remote or doing some programming that we can do in the office. Probably the biggest, thing that happens or could happen that we have to manage is the potential for infection. Of course, when you're doing any surgery, there's the risk of infection. When you're placing these devices, there is that possibility too. So, I do, I don't know, somewhere around the 50 to 100 of these things a year, and about every 5 years, there's someone who may develop a wound infection. And if you get an infection of these devices, you do have to remove and replace them. I've never seen any dangerous infections, but the fact that they are, not human tissue, if they do get infected, they do require removal and replacement. So unfortunately, that's a pretty rare thing. I guess, sort of the final message is that these things are not normal. Nobody is supposed to have incontinence of any kind, and that we have a lot of variety of treatment and a lot of very hopeful treatment for long-term control. I appreciate everybody coming out, and hopefully we've provided you some good information, and just let us know if you need anything else, and have a good evening.
Great. Thank you, Dr. Carey.